Everyone, I would like to welcome all of you to the Global Mental Health Action Network's Mental Health for All webinar, the first one of 2023. Very excited to connect with all of you. To get started, I would love to encourage all of you here on the event to please introduce yourselves in the chat. If you can provide us with your name, organization, and country. The country that you're joining us from, that would be fantastic so that we can start the connections going. A little bit about myself. My name is Farah Arabe. I serve on the advisory board of the Global Mental Health Action Network, and I'm also the founder of itotheN Consulting, which is a small international development consulting firm that focuses on the early formation of the human mind and heart as catalysts of global change. I am very excited for our webinar today because we're going to be talking about progress that has been made in 2022 as well as priorities for 2023. And as all of us here know, mental health is a very complex topic, and we're hoping to capture those intersectionalities as we discuss with our panelists the interactions between mental health and youth and climate change or specific population groups. I'm very excited for our amazing multidisciplinary team of panelists today, and I'm going to encourage them to please introduce yourselves. If you can tell us about, you can tell us your name, about your organization, and the work that you do, that would be fantastic. I'm going to start off with Dr. Malek, who is on my right. If you could please kick us off with introduction.
Thank you very much, Farah, and welcome everyone to our webinar today. I'm Malek from Tunisia. I'm a medical doctor by profession, currently doing my residency in psychiatry and psychotherapy in Germany and conducting a Master of Science Public Health by King's College London. I'm also founder and president of Carthage Health Association in Tunisia, which is an NGO working on the promotion of research and advocacy in public health.
Great. Thank you so much, Dr. Malek, for being here. I'm going to pass on now the virtual mic to Oluwaferanmi Omitoyin.
Hello, everyone. I'm Oluwaferanmi Omitoyin from Nigeria. I'm the Youth Vice President of the International Association for Youth Mental Health. I'm a medical doctor by profession and also a co-founder of the Panacea Project, an NGO that works with young children and youth in the community to help them achieve their dreams. Thank you.
Thank you. Donella, would you like to go next?
Sure. Thank you. Hi, everyone. So happy to be here. My name is Donella Besada, and I'm a health economist and health systems researcher based in Cape Town, South Africa, working for the South African Medical Research Council. So yeah, the work is pretty varied, but over the past maybe 4 to 5 years have been working very specifically in the space of mental health and financing. And just to say, a lot of the work that will be presented today has been in close collaboration with Professor Crick Lund, who works for the Alan Flisher Center for Public Mental Health and now at King's College, and Dr. Sumaya Dokra, who we collaborated with very closely based at UCT as well. And thank you for this opportunity.
Thank you, Donella, for being here. And Elaine Flores, would you like to close us out on this round of introductions, please?
Yes, thank you. My name is Elaine Flores. I am a Peruvian medical doctor and mixed methods researcher. I have a PhD in epidemiology and population health from the London School of Hygiene and Tropical Medicine, where I am also a research fellow now in Planetary Health. In a joint venture between LSHTM and the Stanford Center for Innovation in Global Health. Most of my research is focused on the impact of climate change on health and mental health outcomes. I am a co-PI of Environment for Women and Women's Health project, and I'm also involved in several initiatives in both fields globally.
Wonderful. Thank you so much, Elaine, for being here with us today. I would like to invite all our webinar participants to please send your questions in the chat. We're going to have a time allotted at the end to read out loud these questions for our panelists to answer, and also to answer any other questions that might come up at that point. But I encourage you to please enter them in the chat as we go along. Finally, I have some very exciting news to share, and is that the Global Mental Health Action Network is launching the 2023 Action Plan. It's a document that was the result of extensive collaboration with our network of now more than 2,400 members. And the link should be in the chat for you to access it. I invite all of you to please take a look at our action plan for 2023, highlighting some of the priorities that our network has come up with for this year. Okay, so without further ado, now we can get into our conversation for today on what have been our achievements in 2022, as well as some of the priorities for 2023. I'm going to start with Dr. Malek, who's joining us from Tunisia today. And I wanted to ask you, Dr. Malek, what did the media reporting on mental health look like in Tunisia in 2022? And this is a very interesting intersection between mental health and the role that media has in how it portrays mental health in a specific location. Could you tell us a little bit about what did it look like in 2022 in Tunisia?
Yeah, thank you very much, Farah. So I will start with a very concrete and recent situation. Last week in Tunisia, a medical trainee attempted suicide in her workplace. And we got media reports that clearly mentioned the means used, gave details on the private life of the victim that maybe it may help identify her, did not cite any number of means of assistance for the audience that may be exposed to suicide risk, speculated about the possible causes that led to the attempt, and have simply made everything that is not recommended by good practice guidelines regarding media reporting on suicide. So such a careless media reporting on suicide is not an exception by us, but unfortunately a norm. Already in 2015, there has been a wave of suicide among children in a peri-urban area in a region of the center of Tunisia. At that time, a Tunisian television program invited different victims' relatives to discuss the topic of suicide. And one of the mothers read her daughter's farewell letter publicly. Media coverage was then incriminated by some pedopsychiatrists in Tunisia as responsible for the extension of this wave. This is the so-called Werther effect. And the Ministry of Health conducted 5 training sessions for journalists in partnership with the Tunisian office of the WHO. So I don't think if you, I don't know if you want me to report further on perhaps the way we as Carthage Health Association try to deal with such situations.
Yes, please, Dr. Malek. I would like to know how, I think there's a new mental health curriculum for journalists in Tunisia that will have an impact on media reporting in 2023. Can you tell us more about it, please?
Yeah, so I think confronted with such reality as a civil society organization, we have the choice between the classical reactionist approach of condemning all poor practices that do not comply with our values, or opt for long-term and sustainable approach, moving away from monitoring and responding to negative media coverage to enhance outreach with media professionals and work on the roots of the practice we are considering as poor. I mean, raise awareness, disseminate knowledge, build capacity, and promote a new culture of practice. And one of the lessons learned from the COVID-19 crisis was that the most determinant factor for the public involvement was not what the message told is, but who was telling it and how it was told. And my conviction is that this should be a founding principle in our action at a community level to promote mental health. So as far as we are concerned as public health experts engaged at community level, I think it's crucial that we adopt a health promotion approach informed by health psychology models and seriously reflect on the possibility to conduct behavior change interventions to promote more responsible media reporting on mental health and suicide. Because, you know, for journalists to report on mental health without considering ethics and best practice guidelines is a behavior. And for an editor-in-chief to validate such content for publication is a behavior. And for the finance director of a media institution institution not to see any problem in adopting an audience hunting strategy based on the buzz resulting from sensational reporting on suicide is also behavior. And for a marketing director of any brand to finance such media outlet and have advertising spots on it is a behavior. And for a media regulator responsible not to actively work to address such challenges is also behavior. Even for the average citizen to consider such reporting as socially acceptable and totally normal is a behavior. And every behavior is influenced by barriers and incentives that need to be understood and tackled one by one to produce change on the long run. So in Carthage Health Association, we identify the lack of knowledge and skills as one of the most disabling barriers to attitude change among journalists. And we assume that in order to have a foothold in the complex media landscape as experts from the healthcare community, we have to make an offer. And we thought that the most precious offer and the most precious thing an expert can share would be knowledge. So we actively worked on the design of interdisciplinary training curriculum, currently in cooperation with Deutsche Welle Academy, the official media training institution of the German international TV channel, with whom we are working on the design of a mental health training massive open online course, MOOC, for journalists in the Arab world. On the other hand, we are also having a partnership with the National Syndicate of Journalists and the Institute of Press and Science Communication in Tunis, and we are working to develop a curriculum on universal health coverage targeting journalists in Tunisia. And we are also working to launch 3 national rewards for the best media reports on public health and encourage journalists to report on mental health in a responsible way too. So our strategy in the middle term is to unify both contents, I mean mental health and universal health coverage, in one training framework through which we can also advocate for the integration of mental health services in the basic package of UHC in Tunisia too. So our design is furthermore based on a gender transformative approach and a human rights-based approach. I mean the design of these curriculums of mental health and public health too. And our goal on the long run is to produce a high quality training content that is freely accessible online for journalists in Tunisia and in the Arab world. And in this way, we can help create a more supportive environment for good practice.
Yes, thank you so much, Dr. Malek. You're seeing a lot of claps and thumbs up and hearts flying through your screen because I think it has resonated with many people in our audience. We have Stu Baker saying, I totally agree with Malek. Media reporting, being embedded into core journalism training is key. And it is true, and we hope that the positive impacts that this is going to have in 2023 can somehow scale up to go beyond the Arab world. But thank you so much for sharing with us that great initiative. We're going to move on now to our next speaker, Oluwaferanmi from the International Association for Youth Mental Health is joining us from Nigeria. Oluwaferanmi, I'm particularly excited to ask these questions to you because I'm also very much in the field of youth and children and their mental health. But it's always very tricky to incorporate them into the design, planning, and implementation of mental health services and programs. Can you tell us what role can the youth play in the design, planning, and implementation of mental health services and programs?
Hello, thank you very much. I think the first way to tackle this is to reiterate the fact that it is important for young people, youth, to be involved in the processes in the first place. Because when young people are involved from the start, not just ask for their input here and there, but they are part of the decision making, they are part of the planning. It helps to get a perspective from the young people on how programs and things should be implemented in such a way that it will take that perspective of a young person. For example, you can't just set up a program that is targeted at young people or targeted at helping to facilitate the positive impact on the mental health of young people without having any young person on the board that makes that decision or that plans the program. So I think the first place to start from is getting youth involved. And for us at the International Association for Youth Mental Health, we have young people, we have youth on the board. So we don't just have adults, we don't have old people who have who are like in their 60s, 70s making the decisions. We have young people also putting in their input and also knowing that their inputs count. So that's on the one hand. Then on the second hand, young people can do things in their own little ways. It necessarily not doesn't have to be on a global scale to begin with, but then in your own on the local scene, we can have young people doing things. For example, in implementation of mental health services, young people can be involved in providing peer support. So we have people who have lived experiences. You have people who have gone through things, counseling, helping other people, young people who are going through similar things. I think that's good. That's quite beneficial, and I've seen situations and where this has been institutionalized and actually produced tangible results. Then also, I think young people are also responsible for creating awareness and education as regards mental health issues. Okay, for example, in West Africa, in Nigeria, or for developing countries where the enlightenment, the education, the awareness of mental health issues may not be as pronounced as in other countries based on development, culture, religion, different practices that affect these things. I think it's the responsibility of the young people, the youths in the community, to find a way to ensure that their fellow young people, number one, are educated. Number two, try to educate the younger generation. I found this especially useful. I'll just branch a bit. I was involved, like I mentioned earlier, I work with the Panacea project, and one of the things we did was to go to high schools, secondary schools, to educate young people. So I realized that going to the younger people, the high school students, the secondary school students, getting them involved and educated from a young age, by the time they grow up with the consciousness and the awareness of what they are supposed to be, how to actually build a true and a kind world, how to relate with people, how to help people. So I think that's a very important aspect of what young people can do. Then also I've seen in my community, I've been involved in so many community health awareness outreaches. I've seen young people do a lot of amazing things, going to the communities, educating them, speaking with their elders. The truth is that young people in their culture, in their element, they know how they can get messages across to the elderly people in their communities. Truth is that a lot of elderly people, they've lived their lives and they've grown up with particular sets of beliefs that they're used to. So, and change doesn't come so easily. Nobody really likes to change on a platter of gold. So the young people in those communities understand the elders in their communities. So it is their responsibility, I believe, because an external person may not be able to achieve that goal, like trying to convince people in the community. It will be good for the young people within the community, either working individually or working with external bodies, to participate in ensuring that members of those individual communities actually get the message, and they try as much as possible to create education and awareness. Then also, I believe that young people have a lot of ideas to give, both for social media campaigns, just pitching the ideas to bigger organizations that are already involved, etc. I think that these are things that young people can actually participate in. Then finally, I think young people should youth should start getting involved in government positions. Young people can start running for government positions, get involved. I think it's important to not just stay on the, I know it's not easy, because I mean, nobody just gives you the opportunity, but in the little way you can, just try to get involved so you don't just have a say, you can have your way also. Because when you have the opportunity to get elected or get appointed in some of these positions, then you actually have the power to actually make some direct change. So thank you very much.
Thank you so much for that powerful message. And as I was just like with Dr. Malek's intervention, I think it has really resonated with our audience today. We have David Kavanaugh saying, Oluwaferanmi is 100% correct. Young people have the legal right to have their voices heard within relevant planning and delivery of mental health services. This is clearly underpinned legally by the United Nations Convention on the Rights of the Child, Article 12. Mental health service providers should ensure their practice is in line with this international law. So there isn't only a strategic relevance to incorporating youth into mental health planning services and delivery, but it is actually part of international law. Thank you, David, for sharing that with us as well. Okay, we're going to move on to our next panelist for today, and we're going to go to Donella. Donella is joining us from South Africa, from the South African Medical Research Council. Donella, thank you for being here. Could you tell us a little bit about mental health investment case in South Africa and why it is important for mental health to be integrated into the national health system and other universal healthcare financing schemes?
Sure. Thank you. So the way that this project was born was, unfortunately, it led from a crisis that, perhaps a lot of you have heard about, the LSHTM crisis in 2018, where government has been working towards trying to deinstitutionalize care and kind of put it more towards community-based services. And what we realized in that crisis is that community-based services hadn't been adequately resourced or developed yet to allow for that to happen. And so what we needed to know first is how is our money being spent initially before even building up the investment case towards, what resources do we need to start investing in? So the reason why we needed to that is because the way financing arrangements happen in South Africa is that you get these allocations that go towards the provinces, which are the level where we implement services. And then the provincial departments are responsible for kind of dividing up the resources that come from the national treasury towards their own priorities. But what we realized, so when we did this costing exercise, what we realized is that in absolute amounts, South Africa was actually spending kind of within the lower range of global recommendations of what we should be spending. So globally, by WHO recommendations, government should be spending between 5 to 10% of their health budgets towards mental health services. And so what we discovered is we actually are spending 5%. But what was glaring and alarming is that we have over a 90% treatment gap in our service delivery. And our services are very hospice-centric, and that's what's leading to the high cost of service provision and the huge treatment gap. So that kind of provided us with the baseline for which now we needed to see how do we reform our services to become more efficiently delivered and also to kind of limit that treatment gap that we're seeing. And so we built up this investment case, but drawing on global methodologies around how to do a return on investment. But what we soon realized as well is that a lot of these global methodologies don't fully account for the context and baseline reforms that need to happen in order to actually achieve these returns. Particularly if you have a context which isn't investing enough sufficiently in that baseline reform. So, if you have an intervention and it has this level of impact, it assumes that you have the infrastructure, the governance arrangements, and the human resources and the supplies to deliver that service in order to achieve that measured impact. And so what we did is kind of try to make an expanded return on investment methodology, which takes into account all that baseline reforms and the health system investments required to actually achieve those gains. And we know that, of course, that may kind of compromise the absolute return on investment that you measure, but what we wanted is for a much more realistic estimate of what investments we need and what the potential returns will be. So we assembled a portfolio for the Department of Health and Treasury over a 15-year period, looking at a wide range of different conditions, including substance use disorders, intellectual disabilities, and the range of MS conditions, and recognizing in particular in South Africa, we also have huge substance use disorder concerns, which kind of came to light also particularly around the COVID epidemic. But what we also realized is that we needed to build consensus, and it shouldn't be kind of an approach that's undertaken by researchers or academics in silo. And really through that process, you really get a lot more buy-in. And first of all, working with the Department of Health, it facilitated incredible access to data and all the stakeholders. And so we also, what we did is we we did a Delphi exercise where we brought in multidisciplinary experts and tried to build consensus on what interventions should we be exploring for our investment case and platforms of services. We obviously have a global evidence base there, but what we need to do is nuance it for our setting and actually have consensus by our local stakeholders as to what they see should be our own priorities. In addition to that, kind of recognizing the intersectoral nature of mental health services, and this links very much to my PhD, we also convened panels of different departments of health across the different provinces. So we did this kind of World Cafe methodology where we brought people together from the different departments and asked about what the challenges to intersectoral working is, because this very much links also to our mental health strategic plan, which calls for intersectoral collaboration, but there's no real understanding of kind of the governance challenges that limit the possibility for that to happen, and also the siloed financing mechanisms, also the different kind of priorities of the different departments. How do we bring that all together? And so then in addition to that, we also kind of had sustained dialogue both with the Department of Health and Treasury, and what we call here a mental health think tank, which has also been put together by the Department of Health. And so it kind of, this process had ongoing collaboration, feedback, in order to ensure that it was a collective process that had full kind of consensus. And so in terms of how it builds to the NHI, you know, and UHC finance, so South Africa is building towards, you know, planning a national health insurance mechanism similar to what we call the NHS perhaps in the UK. And the reason why we need this, I mean, is we have a extremely divided two-tiered health system in South Africa, where the private sector consumes a large amount of resources and it provides services for less than 20% of the population. And so we really have an issue. And also in South Africa, given that it's a middle income country, we're really not achieving a lot of our targets. Our broader Millennium Development Goal targets, and now we're seeing an even added complexity with our Sustainable Development Goal targets. And so we need to start making our financing for our health sector much more efficient. And so the NHI naturally kind of makes sense in terms of a way to start pooling resources, also ensure that there's more competition in pricing. The private sector at the moment, the prices are extremely high. And in addition to that, what we know is that we need to start drawing on the resources of the private sector to provide comprehensive services, particularly in the space also of mental health services. We simply don't have enough human resource personnel, particularly child psychiatrists, psychologists. And so we need to start drawing on those resources, but also, of course, investing in primary healthcare and community-based services concurrently. And so, yeah, I mean, and essentially, you know, we know mental health is very much linked to a lot of other disease conditions. And there's, you know, given the inefficiency of spending and the huge treatment gaps, we're very far from achieving the objectives of universal health coverage, which calls for high quality care in the absence of, you know, out-of-pocket or catastrophic health expenditure, which we haven't able to achieve at the moment.
Thank you, Donella. And I think that last phrase of high quality care is one of the important key points right here. Particularly given the different contexts that different countries represent, there are different challenges that need to be tackled in terms of data, intersectionality, multidisciplinary efforts. So it is definitely a complex issue. Ali Hasnain is telling us spending money and spending money wisely or efficiently are two very different things. So for advocates, it's so important to call for greater financing for mental health, but that's only half the story. Which I think encapsulates wonderfully the message that you're here to share with us, Donella. Thank you so much. All right, and now we're going to move on to our last but not least panelist, Elaine Flores. Elaine is joining us from the London School of Hygiene and Tropical Medicine. And we're going to ask her a little bit about the intersectionality between mental health and climate change. So Elaine, what are some preventative measures that should be introduced in 2023 to protect the mental health of vulnerable regions and communities from the effects of climate change?
Thank you. One of the things that has I would say, change, or maybe has been more recognized from lately, is that climate crisis is more recognized now as a mental health crisis as well. Because as we know, mental health builds on this huge array of interconnected social determinants. And at the individual level, we know that our mental health and well-being will depend on everything that has been disrupted, the conditions by climate change. So now we have this increased recognition of the impact of the intersection across policy, academia, media, and the public as well. But we still need to expand on the funding, the research on the mechanisms of these impacts and its effects on vulnerable populations. I have seen recently more calls of this type of fundings, which is hopeful and fantastic, especially for those researchers based in countries that are more at risk and more vulnerable. There is also an increased recognition on the development of new approaches and therapies, for example, those that address climate anxiety, eco-grief, as well as support groups and online communities. And there is also an increased collaboration between health and mental health professionals and climate activists and educators, and also targeted groups, as my fellow panelists have mentioned, youth, journalists, but still there are many gaps and needs, and we must prioritize them through policy, for example, prioritizing and implementing national policies, action plans on the intersection of health, education, economy, security, as well as sustainable development. And this holistic approach should address the psychological and psychosocial impacts of climate change, as well as to be able to integrate these mental health considerations into disaster risk reduction and management strategies, which are already being done, but also ensuring the preparedness and early attention of vulnerable communities, which in some of those plans, they will be more focused on the material and health outcomes, but vulnerable communities will be left with long-term impacts on their mental health and well-being, which needs to be taken more into account. This type of access to mental health resources and services should also be promoting resilience and adaptive coping skills for this type of climate change impacts, especially through community-based programs. And we should not be forgetting about the cross-cultural aspects that needs to be bridged to better understand first the complex relationships between the two fields and the unique experiences and perspectives of high-risk communities and populations. So all of this information will be able to inform the evidence-based policies, but also to ensure that the strategies that are already been in place as mitigation and adaptation strategies and sustainable development programs are culturally sensitive and appropriate and taking into account the voices of historically marginalized groups. And finally, also, well, we need to address the root causes of climate change and the unequal distribution of its impacts. Also through policy and advocacy aimed at these strategies and fostering further collaborations from the academia to policymakers, practitioners, but also addressing the disbalance that we know that exists between countries in high-income countries and low and middle-income ones. So yeah, more or less, we have hope. I believe that we have like these impacts are being more recognized, but there is still a lot that we need to do.
Thank you, Elaine. And I think that is a common denominator among many of the intersectionalities in mental health is that we've made progress, but there is still plenty to do So thank you for that message, Elaine. Well, now we're going to start our Q&A with questions from the audience. As you have seen, the questions have been popping up in our chat as well as in our Q&A. And so we're just going to read them out loud. And if anyone also has questions as we are talking, please feel free to enter them in the chat or let us know. I'm going to start with a question for Dr. Malek that we had in the chat. What is the impact of the training for journalists? Are they now doing positive reports on mental health? As you mentioned about behavioral change, can this training play any role in reducing mental health stigma and negative stereotyping?
Yeah, thank you very much for Harun for asking this question. So short clarification, we are now in the design phase of the curriculum. The curriculum was just designed and validated by both partners, I mean Carthage Health Association and the Deutsche Welle Academy. And the MOOC, the Massive Online Open Course itself, will be launched in March. So we are in between now, but I will respond to your question. We will actively monitoring and evaluating attitudes of reporting of participants after the training, and our intervention will include data collection time points on these attitudes before and after the learning process, because, you know, journalist training can play a very important role in reducing stigma associated with mental health by promoting accurate and sensitive reporting to mental health related issues. And the training was designed to provide journalists with deeper understanding of 3 topics: introductory principles and basic informations in mental health, depression, and media reporting on suicide. This can, I think, in turn help to break down barriers and encourage people to seek support also for mental health issues when journalists report on a responsible way. And just information about our intervention while shaping our curriculum, we involve junior health professionals who have been taking a training on global mental health provided by the online learning site we are hosting in Carthage Health Association of the Global Health Online Program of the University of Washington. And we also had journalists working with the association who were checking the content from a journalistic angle of view to test its readability and understandability by the non-expert public. So we are trying already to create this supportive environment inside our organization, because we think that we firstly have to try to be the change we want to see in the world, as Mahatma Gandhi says, and this is in the heart of our approach. Perhaps I can tell shortly about one of the biggest challenges we are facing to mobilize journalists currently in Tunisia. We have a lot to do, unfortunately, with the economic and political crisis, and it is naturally very challenging to try to keep public health and mental health on the top of journalistic priorities because of the ongoing crisis, but we remain committed to find a way or even to rebound on crisis-related issues to create a one. Thank you.
Thank you, Dr. Malek. And we look forward to hearing everything about the program and how it turns out. Just a reminder to everyone right now in the webinar is that all these conversations continue on Circle, which is our digital platform for interaction and connection. So if you want to continue these conversations, please join us there. We also have other questions. We have a question for Oluwaferanmi. How do we get young people under 18 years old engaged in the mental health advocacy, since they have to get consent from their parents? And how do we recruit them into an advisory group?
Okay, this is quite tricky because of the legalities, but this is also the importance of having our parents or the parents educated and involved also. And that's why, I mean, if young people have, like, for example, if you have a young person you want to get involved, with parents who are also educated and are already aware of mental health challenges, I mean, it's going to be quite easy as compared to those individuals who their parents do not actually have the exposure. So I think one of the first things is creating opportunities on a large scale for young people. For example, you can have opportunities for people from aged 15 to 18, not necessarily just casting out a wide net, saying people from the ages of 18 to 40, etc. So you can have opportunities for people, for young people within that specific age bracket that are minors, and then obviously getting their parents' consent is also important. So it's important that as mental health advocates or professionals all around the world, or people who want to get involved with this young group of people, it's our responsibility to ensure that the parents the peace of mind of the parents are how do I put it? You have to assure the parents, exactly. You have to assure the parents of the ramifications of what their children are going to be involved in, because quite frankly, these parents have genuine concerns. If a parent says that I'm not allowing my kid get involved, the parent is also concerned for the child, because they are not certain, they don't know the fullness of whatever they're going to be getting involved in. So it is the responsibility of whoever needs to be involved or wants to get these people involved to ensure that the parents are fully aware, and then on a case-by-case basis, you can then go from there. But all in all, I think it's important that a wide array of opportunities are opened up to these young people on a global scale from even trusted organizations, so that then it's easier for the parents to agree and fall in line. Then also, but more importantly, like I said earlier, getting the adults, getting the older generation educated and involved in processes also. Like I said, I never said my take on mental health as a whole is not just getting the youths involved alone. The youths need to work with the older people. So it's a symbiotic relationship whereby the young people and the old people work together. So I think by the time we have the elderly people, the older generation, or the parents being more aware about what mental health entails and the benefits of having their children involved at a very early stage, I think is going to help.
Thank you so much, Oluwaferanmi. It's true, there are always challenges to working with youth and children. Also just challenges in working with many different types of population subgroups. And we have actually a very interesting question that could be answered by anyone on the panel, because it is specific to migrant workers. And it says, migrant workers and their families, mostly from developing countries, have mental health issues. How can their issues be addressed? And I know this is not the specific focus of any of our speakers, I think, today on the panel, but I think it's important to highlight how there are very unique needs depending on the subpopulation groups. And if anyone has any insight on this question, I would appreciate it.
Perhaps I can interact with the question. So as far as migrants are concerned, I think we have a lot to do with transcultural mental health, because mental health interventions to address challenges related to mental health care of migrant populations have to be tailored also regarding the social cultural aspect of origin of the migrants. I have already had experience dealing with migrants in Switzerland, in Germany, and one of the most challenging issues of the daily practice is to understand what is normal and what is not normal in the culture of the concerned person. As far as public health policies are concerned, I think we have to foster preparedness and programs of not only mental health, but also of psychosocial support, because these people have been experiencing traumatic events and otherwise in their way to their destination or in their lands of origin because of war or conflicts or any related issues. So I think it's a whole landscape, and there are a lot of determinants that need to be tackled and considered to design interventions adapted to migrants' populations.
Absolutely. Thank you, Dr. Malek, for tackling that difficult but very important question. Question for Elaine. The concept of eco-anxiety is spreading fast to identify the impact of climate on well-being. Do persons with lived experience feel this concept appropriate, or is it perceived as a top-down label? Do you think there is any difference in experiencing that from the global north or global south locations?
Thank you. I have tried to draft a bit of a response actually on that, but it is based on, well, I am trying to summarize, but the thing is, we still need a bit more studies, a bit more evidence to know exactly why, and to fully understand actually the complexities between how people experience eco-anxiety, how it affects them depending on their personal circumstances, and also the support that they receive in their communities, and as well as their cultural and social background. Some people actually will feel that definitely this is like a top-down label, but we still need to know a bit more to understand also how to address it better.
Farah, I think you have to activate your microphone.
Thank you. Thank you. We also have another question on mental health being rarely discussed at the Conference of the Parties. How can it be made a bigger priority for discussions there and also at a national level, particularly in developing countries where priorities and budgets are stretched thin?
Yes, because the thing is, we may have like some ideas, some things that we can push forward, you know, increasing the awareness, including, of course, mental health experts and advocates to participate in this type of discussions and negotiations that occurred at the COP, allocating enough resources to address this type of mental health issues that will be able to make a change, encourage collaborations between the different people involved across the fields, environmental science, mental health, and health organizations as well, to have like a coordinated message and effective response. We also need, as I have mentioned briefly before, to integrate this type of policies, integrate mental health into environmental protection and response to this type of risk, to ensure, of course, that mental health impacts are minimized. These may help to make mental health more significant priorities in these discussions. We also need to be aware that there are strong links and other priorities in place that needs to be held accountable as well. But that could be a good start to increasing the priority in this type of discussions.
Thanks, Elaine. And talking about priority, we have a very interesting question from an anonymous attendee, and perhaps this might be a good question for Donella. As advocates, if governments are unwilling or unable to give budgets to mental health, what is more important? Asking for mental health services to be integrated in the treatment of other health conditions, or asking for standalone funding for treatment of common conditions, such as depression and anxiety? I wonder whether the South African investment case covers which has more financial/health benefits, or if there is a middle ground. That is a very interesting question.
Thank you for the question, and it is interesting. So In the context of South Africa planning towards a national health insurance mechanism, in the long term, we're advocating for an integration of mental health within broader health service delivery, particularly also because of the high levels of comorbidities we have with mental health and our other kind of competing health priorities, our infectious diseases in South Africa, HIV and TB, and now also our growing burden of non-communicable diseases such as diabetes and hypertension. So that complex interplay necessitates an integrated model of service delivery. Plus, it's more efficient when you have, one health provider that's able to kind of address the myriad of conditions that people kind of present with, and this is kind of moving similarly away from how we had seen kind of investments in the HIV space before. And now we say, no, you have to kind of integrate it with TB and other kind of conditions. In addition to that, what we need to do, we're trying to piggyback onto services that have historically been advocated for more strongly and have more services and resources allocated towards it. So, potentially what we model, for instance, are high returns for investments in perinatal depression. And what we know is we have strong advocates for maternal child health services here. And so if you can ensure that the service providers, we have high rates of attendance of antenatal care, that's a strong opportunity to integrate mental health screening and counseling services within that. In the short term, what we are calling for is what we say a conditional grant or a conditionality of funding. And so the way financing in South Africa happens is it's two streams. Either you have a conditional grant where it's kind of earmarked funding for a particular condition, or you have kind of the broader allocation to provinces called the provincial equitable share. So in the short term, we're saying we do need some conditionality on mental health services to build it up so that it is in parity with other conditions once we move towards integration. Because we have such significant underinvestments at the moment at the primary and community-based levels, we need those kind of protected investments to ensure that we can now start moving effectively towards decentralization of services without compromising the quality of care as we transition people. And to be clear, we're not saying some people don't require hospitalization. They absolutely do. However, in the absence of community-based services, what we're seeing is that people are essentially living in the hospitals for years and years, and that cost is kind of obscene. And then in addition, with respect to what we're showing in the returns, we kind of modeled as many conditions as we possibly could for which data was around. So it did include conditions such as depression and anxiety, but also things like bipolar disorder, schizophrenia, drug use disorders, intellectual disabilities, in recognizing, and we did know because the global investment case kind of modeled depression and anxiety, and it showed these huge returns. And we knew that those conditions might yield higher returns, one, because kind of remission rates are higher. The service delivery is relatively cheaper than what would be required, for instance, for conditions such as schizophrenia and bipolar disorder. So, but we modeled both. And then what we're showing in the investment case is that, obviously to advocate for investments, you tell government it's a good return on your investment, but in addition to that, South Africa and the global community has human rights obligations to invest in mental health services. So even for conditions that don't necessarily have a high economic return, there are social returns that we kind of calculate in terms of improved well-being and capabilities and capacity to participate in society. And those in and of themselves have value. And so we're advocating for both kind of concurrently. And the last thing in terms of, trying to, within fiscal environments that are very limited, particularly now with the COVID crisis, what we demonstrate is actually oftentimes the price of inaction is higher than the price of action. So what we showed them actually is if you do nothing and you leave the service delivery as it is, actually what you're losing to the economy, to the health services, is higher than what it would be if you just invested in service delivery.
Thank you so much, Donella. That was a very insightful answer. And in the interest of time, because we only have 5 minutes left, we're going to move on to our next section, which in the tradition of our mental health webinar series, we encourage our panelists, we ask our panelists to, in a short way, in a tweet length way, answer or complete the following statement. To make mental health a priority this year, we must, and I'm going to start off with Oluwaferanmi.
We must be more deliberate about our actions and try to get the youths involved more often. Yeah.
Dr. Malek, would you like to go next?
Yeah, I think we have to make it a priority. We have to work more on bridging the gap between experts, policymakers, funders, and communities on the ground, and work on the capacity building of non-expert public to help foster a knowledge continuum in mental health.
Elaine?
Yes, we must invest in community-led resilience building and prioritize policies that promote population mental health and well-being and address the root causes of climate change impacts on mental health.
And last but not least, Donella?
To make mental health a priority, I think we have to recognize the progress made in the field, draw on the strong evidence base, form a joint collective, and work together to strongly advocate for mental health to become a priority.
Wonderful. Thank you so much, Dr. Malek, Elaine, Flores, Donella, Besada, Oluwaferanmi, Omitoyin. Thank you so much for having been a part of this panel. I also want to thank the audience for participating in this conversation. And I just want to close out by reminding you of our GMHAN action plan for 2023. It's officially being launched today with all of you. The link will be on the chat for you to please go and visit it. Also, I want to remind everyone that our next webinar will be focused on data advocacy, so you can't miss it. The registration link is also going to be on the chat. And finally, if you want to continue the conversation, please join us on Circle. This is the forum that we use to connect and support each other and exchange all the information and questions that we have. So please join us. The link to join Circle will also be on the chat. Thank you again, everyone, for joining, and we look forward to continuing connected and interacting on mental health. Thank you, everyone. Have a wonderful, wonderful week ahead.